I wanted Dan to just introduce me as I'm someone who, my husband still loves me after 40 years, and my children are at an age where they think that I finally know something. So when Dan first, he emailed me about coming to this conference and speaking at this plenary, and I thought to myself, oh, poor Dan, he's been hacked. Somebody is trying to get into his credit line and trying to weasel some money out of him. I couldn't imagine why he would be emailing me about this. So like 3 or 4 emails later, he finally says, hey, dude, what is up? I'm trying to ask you if you want to be part of this plenary. So I graciously said, I'd love to do it. I am terrified of speaking to all of you, but now that I've been here, I realize I'm speaking to the choir, so this is just a wonderful opportunity for me. And I wanted to just take these next 40 minutes to share with you some of my journey about what I've been learning and what I've experienced in this vast land of integrated behavioral health and primary care. So let me start with the disclosures, and maybe now I have to say something about a disclosure. I have no financial gain here. As you can see, 25 cents for a book is nothing with a royalty. And I had the opportunity to work on that book with the most amazing people, Dan being one. So it was such a learning opportunity for me. I want to give you a little bit of a version of my backstory so that you have a context for the stories that I will share with you and the perspective that I bring. I want to talk about a mythological tale because that's where I think we are. And kind of champion us forward on our onward journey as we go away from this conference, very inspired and full of new ideas. So let's begin. Let me tell you a little bit about this backstory. I have been in love with systems from the beginning. It's been a career magnet for me. I started working in family systems theory in the 70s. In the 90s, I was introduced to multi-professional education. I worked at Wright State University, had a Kellogg grant where we had nursing students, medical students, professional psychology students, and divinity schools all in the same classroom early in their careers. We had them going on home visits. We had them in their ethics class together, debating clinical priorities. It was invigorating. That really launched me into the field of family medicine, and I've really hung my hat in that arena for the last 20 years. So I can say that family medicine and behavioral health integration have been my home base for a long time. Although I've had many different sites where I've been working, I've had about 5 different residency sites where I've been able to work. So some of my colleagues accuse me of having multiple move disorder, and there's no medication for that. So at this point, I'm just learning how to manage it. So let me tell you, 5 years ago when this book adventure took place, I was really swirling from trying to figure out what the hell is going on in this world. I would hear about some kind of holistic biopsychosocial model that was out in California and hear about the champions that were putting life together in a holistic way, and only to learn that it evaporated, that it was gone in a poof when the funding was gone or a leader changed. Or other times I would come on something in the listserv and realize, oh my gosh, out in Kansas, I can't believe they have this clinic there. They've been doing this very cool thing, and they've been doing it for years. So I was swirling from all of this different turmoil of trying to figure out what are people doing? What are the lessons learned? What's evidence-based? What's mission talk? So that's what started me on this journey of trying to sort out these stories. And it reminded me really of a journey into a mythological tale. And how many of you have been following the Game of Thrones? just a few. Thank goodness, because I can't get all the characters straight. So you'll have to forgive me if I reference it in a way that doesn't fit with your understanding of the story. But with any story, any mythological tale, it really starts with a utopian view, a Garden of Eden. And we started out this conference with our own utopian view. Our health is primary. This is the world of integrating biopsychosocial worldview that is person-centered, patient-centered, team-focused, community-based. All of the things that we think of when we think about are really the goal of where we're trying to get, our promised land. So as we do this, as you think about a mythological tale, we really realize that every mythology has a wall. In the Game of Thrones, the wall is ice and rock and its magical powers that separate the Northland from the Seven Kingdoms. We've had our own divide. We talk all the time about the mind and the body split. The heart and the physical are splitting. We struggle with this. Think about how we've eroded our cultures over time. We've been living in separate lands. In any mythological tale, the divide comes with all kinds of dissension. There's sibling rivalry. There's struggles over the inheritance. There's all kinds of eruptions in alliances and partnerships. This is where we're at, folks. Think about how if you think about the scarcity of resources and the struggle between physical and mental health. In mental health, they've really been landed on the state side, our bankrupt states, to get funds from block grants and from state governments, whereas the health centers, the community health centers, get their funds from the federal dollars. Talk about sibling rivalry. Talk about jealousies. How can we possibly blend together and come together? These are the kinds of things that have really separated us. And when you think about it, the Great Divide comes in the terms of how we understand what is wellness. In the medical world, we have A1Cs, CBCs, HDLs, LDLs, TSHs, BUIs, BMIs, and BUNs, and I'm sure there's many more. In the mental health field, it's quite different. We have things like self-awareness. We have other things, emotional regulation. We have relational intimacy. Is there anything in that language that overlaps? No, we can't speak each other's language. One way that we've been trying is with, I think, our PHQ-9s, GAD-7s, our MDQs, are trying to fit into the language of our medical care. But let's go on. Let's spend some time dissecting our mythological tale in a way that we can understand about integrating the physical and the mental health again. I want to dissect it in three ways. I want to talk about turf, I want to talk about turmoil, and I want to talk about tenderness. I think if we talk about these three areas, it will give us the compass for us to travel along this journey of integrating behavioral health into primary care. So let's start with our turf issues. Look at these pictures. Any doubt in your mind which landscape belongs to physicians, which one belongs to MAs and nurses, and which one is behavioral health? I think of these as spa retreat versus Top Chef. The worlds are so different. Behavioral health, we think yoga, we think candles, we think new age music, we think about calm, to rest, to calm those inner traumas, to give a sense of relaxation. In medicine, it's all about having an algorithm that we can follow to give the best evidence, best practices for our patients. You order vaccines and shots happen. Call for an EKG and a machine spits out life-saving information. We don't really live in the same kind of landscape or territory. There's no time to ask if an EKG is done, how do you feel about these electrodes on your chest? And does this remind you of when your brother tortured you as a child? No, is it any wonder that we're very puzzled by each other's pace and space? Look at our signs. Oh, goodness sakes, let me go back. Look at our signs. Okay, this is a typical in and out sign on the door of our exam room. It's all about going in. Physician in the room, nurse in the room, labs being drawn, referral coordinator in the room, EKG being done in the room. It's like little gypsies flowing in and out of this room. Look at the behavioral health sign in our center. The behavioral health consultant comes out of the room. They go out. You can knock. They will come out and consult with you. They come out for lunch. They're out of the office. We have a very different way of understanding these boundaries and working within our landscape. If you notice, oftentimes medical providers will not go into the behavioral health room. It's like going into the confessional or something. People are afraid that they will divulge their innermost secret sexual fantasies. I don't know. Let's talk about ways to melt the wall. This is something that I think is so promising and I'm so excited about. At Northwestern, we've changed the way we do education. We are starting from year one in medical school, where our medical students are in our clinic and attached to our clinic for 4 years. They have a panel of patients where they build a relationship with their patients. And they have the opportunity to work hand in glove with our behavioral health consultant, who is my psychology intern at the moment, and their social workers. They're committed to that clinic. They go in the room together. They're green at the same time in the same place. They're both deer in the headlights. And through that process, they begin to learn what each other's world is like, what they bring to the table, what they can rely on the other person for. Anjali, my last psych intern, was an expert on smoking cessation and motivational interviewing because she had been part of a research project at Northwestern. She was able to teach right from the beginning some of these motivational interviewing skills to our medical students. This is where you learn a language in the early formation of your identity, not when your identity is already formed. It's so much easier to learn another language when you're 2, 3, 4, and 5. It doesn't work when you're 60 years old. So that's the first turf building, melting strategy. The other one is what so many of you have talked about here already. I think the PCMH has brought new life into our unified mental and physical health care. We are doing things, so many of you have talked about these already, so I'm really preaching to the choir. We have built in into our schedule huddle time so that everybody can come together and you can review the list of the patients that are coming, and the behavioral health person can be part of that discussion where a provider can say, oh my gosh, I forgot that Mr. Sanchez, his wife went back to Mexico, he's lonely. Can you talk to him a little while? Or, oh my goodness, here we have Rosa, she's coming in, she had a miscarriage and she's coming for a follow-up. Can you please check in with her? These are the kinds of things that happen in the moment, at the point of encounter where we need to have the same place, same time, same pace. Also, just living in each other's land. I can't tell you how important this is. And many of you have talked about that. As behavioral health people, please, you need to get comfortable just hanging out in precepting rooms where people are charting, being part of that conversation, learning how to interrupt. And in the same way, medical providers come into the space. have a kumbaya moment with your patients. Linger a little bit longer so that we can appreciate each other's language. So let's not stop there. The mythological story goes on, and the next phase and the next part that I want to comment on is a part about turmoil. Oh my gosh, in every mythological tale, there are these episodes, there are travels, there's journeys that are full of battles, of strange creatures coming around, of new alliances forming, of you can't tell what's going on when the battle is taking place, who will enter, what new kind of machine comes into play. It's always filled with chaos and confusion. And I believe that really represents the experience that I have had in traveling this land. It's more confusion than it is a structured protocol. In the Game of Thrones, you're never sure who lines up with the Lannisters or the Starks. The rules keep changing. So here's how I think is another mindset, a mental map for us to have. We're really in organizational scattered. We need the scatter, though. We need the multiple perspectives, the multiple values in order for us to be on this journey, to be traveling along in a way that makes sense. It's like cooking. It's really like regional cooking. We take the fruits and vegetables that come from our land, we take the spices, and we put things together in creative ways. Sometimes we make a delicious meal, and other times it's completely inedible. But it's an eat and tweak experience. We have to find ways to use the ingredients around us and concoct delicious meals that can feed the multitudes. If you aren't familiar with complex adaptive systems, I would encourage you all to begin to get familiar with this concept because I think it matches how we experience our world in healthcare. I recently went to a conference at Georgetown that just absolutely was mind-blowing because it's like using physics and the new math, theoretical math. But the concepts really apply to our field. And I would encourage you, those people who have that kind of mindset that you like to grapple in conceptual models, to explore it. We are like a mishmash of people. It's not just herding cats, because really we're a bunch of orcs and dwarfs and elves and wildlings and hobbits all trying to work together. And it's a very creative process. So if you think about our primary care world, look, this is primary care, a 2-year-old with a mom and a grandmother coming for a well-child checkup. It's also primary care to have a 50-year-old with COPD and diabetes who's estranged from his family to come into our clinic. These two encounters require a completely different configuration of teamwork. There is no playbook that's going to tell you exactly what to do for these two different types of encounters. And one 2-year-old checkup is very different from the next 2-year-old checkup. So we need to think of ourselves much more like your favorite team, sports team. The way that they work together over time, the way they can anticipate each other's moves, the way that they understand how they can line up together to make a goal takes practice. You have to be in action. We have so many different toolkits out there on the web. SAMHSA and ARC and everybody else has these wonderful toolkits out there, but they are useless unless they're put into action. A hammer isn't a hammer. It doesn't function until you pick it up and swing it. And that's why I think we need to think of ourselves as having a very fluid, flexible way of interacting. There are broad parameters for us to focus ourselves, but there's much more fluidity in it. So, the things that I think help us manage this turmoil are really 2 areas. One is team identity, and a lot of you talked about this, and I got some wonderful ideas from you. So having regular meetings, you just have to have face-to-face. You can't do it through email chains. It just doesn't work. So having regular structured meetings together where you can talk, you can brainstorm, you can discuss, you can give out new information, and you need everybody at the table. How many QI people are still here? Oh, wonderful. We need more QI people on our teams. We need to have our MAs, our front staff, our health promotion, our clinical care coordinators. Everybody needs to be at these meetings and formed into teams. And so many of you have, red, blue, yellow, greens. We have those too, but we also have them attached to food because that's the way I think it sticks with people. If you tell them, what team are you on? It's because we gave them blueberries or the raspberries. That seems to really stick and help people to know what team they're on. And we also tell the story often. We rehearse, okay, we've been working on huddles. Do you remember huddles? What are huddles all about? When are we doing huddles? How are we going to do huddles? And then we add another chapter to the huddles or another paragraph. Whatever we're doing, we're retelling the story of our teamwork together. Another thing that I think just communicating through the EMR is huge. Some of you have talked about your struggling with the stage of shared treatment plans and that kind of thing. So having a format where we do our pre-visit planning, and behavioral health can be part of that pre-visit planning, and also in our shared care plans. So I think that is something that we need to bolster. The other thing is learning lunches. Anything around food works really well. So what is this doing? Okay, the other thing that you have to do is have team tasks. So, empanelment. Oh my gosh, isn't that a dirty job? In our section, we have been struggling with empanelment. Residencies are notorious for having dirty panels, and we are one of them. So scrubbing the list, we have made, everybody wants to have a clean toilet. We all want to have a clean panel. Everybody uses the toilet. Everybody needs to clean the toilet. So we do scrubbing regularly together as a team because it's only as we know our patients, the front staff can tell you who's in the family, or the behavioral health person can say who the significant other is. We want to be able to, the EMR can't tell you who the family is. They can't group the people together. You have to do that as a team. The other thing is working on quality improvement projects. So many of you had such wonderful ideas that I'm taking back to my group. But I think behavioral health people need to get dirty with the data too. Don't stand outside the sandbox and watch and observe and comment like we've been trained to do. Get in there and play with the sand. Somebody said doctors love data, and I think that this is a challenge to behavioral health to get in there and love the data too. There's another thing that we're working on, which I'm not going to go into today, but we're working on a complexity care initiative that's really targeting the moderate complex patients because I think they fall through the cracks. And this is another way that we have my team, we're so excited about how we're doing this, and for another time. So let's move on with our mythological tale. We really, I think with all this turmoil, with all of these challenges about turf, there's something that binds us together, and that the glue is tenderness and affection. We heard it yesterday with Josie's story. Oh my God. It is compelling. We think about her. We have her voice. We have the images in our mind. It binds us together and is our compass for our journey. Think about Sam and Frodo. Oh my dear. They are the personal connection that they had, the protection and sacrifice between them, the shared risks. In the Hunger Games, it was Peeta and Katniss. These are the tales that really keep us glued and our eyes on the prize. I want to tell you, and it brings us to our Garden of Eden, I believe. I want to tell you about one of those tales. This is about Mr. Rencher. 10 months ago, Mr. Rencher went to our community safety net hospital, Norwegian American Hospital, for a COPD exacerbation and alcohol intoxication. Mr. Rencher had been in the hospital 3 other times before that. he had, in the last year, a huge expense for all of us. He couldn't have health insurance because he was paid under the table. He had never had a doctor before. But he came and our team saw him and he connected with one of our docs, Dr. Levine. And Dr. Levine is really this super happy doc. She has incredible, whoops, there's my daughter. I'm sorry. Dr. Levine, she's this happy doc. She's Miss Optimism. She's our poet. And she connected with him and convinced him to come to our primary care center. He came to our center, and as most patients do, the first person you see is the MA. He saw Yadi, and Yadi screened him with a PHQ-2 and our audit. And voila, he came up positive. So she flags Lisa. Lisa comes down, meets with him, screens him with our substance abuse screening, and he comes out positive for substance abuse, mainly alcohol. So we have a discussion with him. They say, you know, what are you thinking about this? He said, yeah, I got to quit drinking. I really want to have that medication that makes you throw up when you drink. I think that's what's going to do it for me. So we said, oh, okay, let's think about that. But, you know, we also want to offer you this other substance abuse treatment. So I think about it. But he said, I want to meet with that psychiatrist so I can talk about that medication, because that's really going to work for me. So he goes away. He vanishes for about 2 months. We don't see him, but he comes back to the clinic because he can't breathe. And he knows he has health insurance now because he got signed up at the hospital and he has Obamacare. He comes in for breathing treatments, and Dr. Levine sees him, and I happened to be there that day. We met with him. We said, you know, we really want to help you with this. Let's have a talk. Can we come and do a home visit? We had a home visit with him. We went to his home, and oh my gosh, there we were in this absolutely tip-top, tidy basement apartment where we saw his collection of hats, where we saw his barbershop tools, because we learned that he was the neighborhood barber. We learned about his HVAC skills and his estrangement from his family who lived on the top floors. And we also, as we were leaving, I said, hey, what's that? And there was a liter bottle. And he said, oh, that's what I drink every day. That's where I put my Irish Rose whiskey. I fill it up. That's what I use. And we were like, oh my God, please don't stop drinking. Keep drinking until we can get you in the hospital. We had no clue how much he was actually drinking. We arranged to get him in the detox unit again at our safety net hospital, and he went. He detoxed, he was discharged, he was referred to our community substance abuse program. He disappeared. Then he came back. We met with him again, and we said, Mr. Rencher, what's going on? He said, you know, I just didn't like that substance abuse place. You know, I felt disrespected. It just was not the place where I was going to go. I need to get my breathing under control here. He said, you know, will you give it another shot? Can you try it? And I said, let me call Carlos. I know Carlos in the residential side. Let's see if we can get you hooked up. We called Carlos together, arranged for an intake, give him the phone number. We're worried that he's not going to be able to follow up because that phone doesn't always work all the time. And then he goes. We didn't hear from him for for 2 months. He comes back. He meets with our behavioral health provider and Dr. Levine again. He had gone to the program for 6 weeks. He was going to AA. He was taking his medications for his COPD, for his asthma. He was breathing better. He looked like a new person. He said, I was so bored. He was so bored. He didn't know what to do during the day. So we got him hooked up with Jesus, our health promotion person, and he got a free gym pass to the gym that's down the community rec center down the way. So he started working out. This man, at this time, I took this picture 2 weeks ago. He was able to go to the AA Thanksgiving dinner. He didn't drink with his family. He's coming back in to see us. I told him I was going to tell him all about you And he was just absolutely thrilled and charged up about doing this. Look at this picture. This is behavioral health. It is not a person in the clinic. It is all of these pieces working together. We punted to each other. There was not a clear path, a clear step 1, step 2, step 3. It was a stop and start kind of process. We didn't always know where we were going with this, but somehow we had a forward moving journey. So I just want to tell you that I think it's these kinds of tales that really bring us together. This is where behavioral health becomes health. It melts the wall. It is health. It's not a separate thing that's added on, but it's the fiber of how we think about health. It's also part of this quadruple aim. It provides provider wellness. Telling this story is wellness for all of us. It's for you, for Mr. Rencher, for Dr. Levine, for my expert counselor, for the MAs, for my health promotion person. Becky wrote, Dr. Levine is a poet, she wrote a poem to him about our experiences together. He has it framed in his house now. It's just really heartwarming. I think these are the kinds of things that telling poems and writing stories help us share the celebration of why we're doing this in the first place. So let me end by saying, in terms of turf, hang out in each other's territory. Think about immersion. Learn the language. Become multilingual. Know that this takes time and practice. In terms of turmoil, take the tools that you have available to you and make something. Do something with these tools. Get dirty with the data. Do pre-visit planning. Get involved in the panel management. Do QI projects together. It's by the doing together that builds your family, your team approach. And lastly, tell the tales. Talk about the stories, the shared experiences that you have. Keep talking about a Josie story. Keep talking about Mr. Rencher. Keep telling the things that really have changed your life and changed the life of our patients. And for that, I want to say I have great gratitude. As I said, I move a lot. Here's just a sample of the people who have really contributed to the story that I tell to you today. So thank you very much.